Hello, this is Louise. I'm here today with Dr. Rick Hayashi, a nephrologist, which is a kidney doctor in Honolulu. Thanks for being with us today, Dr. Hayashi.
Sure. Glad to be here.
My understanding of what a nephrologist does is help people who have chronic kidney disease uh, early on in their disease, but also in uh, dialysis patients and people who have received transplants. Is that correct?
Yeah. So, majority of what I do is take care of patients who have more advanced chronic kidney disease. Their primary care physician can usually handle early chronic kidney disease, but once kidney disease reaches about stage 4 out of 5, we usually recommend that they're referred to a nephrologist. And the rationale for that is once you reach that degree of chronic kidney disease, there's a few things that I do and I focus on, and any nephrologist would. One of them is to prepare for renal replacement therapy. So that includes kidney transplantation and or different forms of dialysis. The other thing that we do is we focus on some of the secondary complications that can arise from having low kidney function. The kidneys do more than just make urine. They control anemia. They control bone disease. They have a lot of other endocrine functions, and so part of what we do when you have stage 4 kidney disease or more is to manage some of these secondary complications. And it's not that I do anything special. I mean, I'm a medical doctor like any primary care physician, but I do have extra training in nephrology to really focus on these issues and to provide very focused kidney-related care.
Can you explain the different stages of disease to us?
Yeah, so there are 5 stages of kidney disease. One being, the mildest form, 5 being the most advanced, essentially, end-stage kidney failure. We stage kidney disease based on a test called the GFR. It stands for glomerular filtration rate, but just GFR. Um, Stage 3 is when we really consider someone having chronic kidney disease. Stage 1 and 2 is when the GFR is quote unquote normal, so it's greater than 60, but there's some other abnormality. So for example, there might be protein in the urine, or there might be cysts on the kidney. There might be persistent blood in the urine, but with a higher GFR level. But once your GFR is below 60, that's now an abnormal GFR. So stage 3, and again, each of the stages is categorized by the GFR. So stage 3 refers to a GFR of 60 to 30. Stage 4 refers to a GFR of 29 to 15. And then stage 5, the most severe form of CKD, chronic kidney disease, is a GFR of under 15, up to what we term renal replacement therapy, which is, basically your kidneys no longer function, so you have to replace kidney function. And that's either with kidney transplantation or any of the forms of dialysis.
When do you first talk to patients about kidney replacement therapy? What stage of their disease are they at?
Well, so it definitely, it's something that's brought up. A lot of it really depends on the trajectory of their kidney failure. Every patient's different, and sometimes we have patients who are they have a very rapid trajectory, and so you can already predict from the time I see them, they're going to probably need to start on dialysis within maybe months, sometimes weeks to months. And so in those situations, it's an urgent situation, so dialysis is brought up pretty much immediately from the first time I meet them. I get referred a lot of patients who maybe just made stage 4 kidney disease, but they had been stage 3 for 25 years prior. Their kidney function is declining by, just a very little every year. And they finally at age 75 reach stage 4. And, they probably would live their entire life without ever needing dialysis or renal replacement therapy. So I don't necessarily bring it up at that point, even though they're technically stage 4. A lot of times I do like to educate patients, though. I will kind of give them just a timeline as far as usually at this level of kidney function. So when we usually start dialysis, once the GFR is less than 10, so generally about maybe 6 or 7, depending on the patient. So Stage 4, when I start to see patients, is usually when the GFR drops below 30. So it gives you kind of a reference numerically, where you are. And so a lot of times what I'll do is I'll plot out the GFR and I'll show them the trajectory. So I'll look back to the 5 years of GFRs, and we'll create a line graph, and we'll kind of project, like, based on your previous rate of decline, we can see roughly when you're going to need dialysis when your GFR drops below 10. And some of that, I use that information to determine when to talk about dialysis, because I don't want to scare patients. A lot of times patients come to see me, they're really frightened because they automatically think they're going to need dialysis, but that's not always the case. And so I may choose not to bring it up initially if I see that their projected GFR decline is, they're already 75 and they're losing half an ml of GFR per year, so they'll probably reach ESRD by the time they're 135, so, and I've told patients that too. I said, based on your rate of decline, you'll probably need dialysis when you hit 120. And, I think that tends to reassure patients a lot, but I'm also very honest too. I mean, like I said, sometimes based on their trajectory, I mean, they're dropping really fast, and, sometimes they need dialysis probably within a few weeks to months. And in those situations, I mean, it's a pretty urgent situation trying to get access in place and getting them ready for dialysis. So obviously in those situations, we're talking about dialysis early on.
And how do you discuss different types of dialysis? How's that decision made?
I kind of make a judgment as far as, what I think the patient would probably do. So, for example, I'll give you an extreme example. So, I have several homeless patients, right? And so obviously if the patient's homeless, home therapy is probably not going to be an option. There's no home to do the home therapy in. If they're homeless, depending on their situation, their mental state, maybe they're active substance users, transplant's not an option. So, in a situation like that, for example, really you're just looking at in-center traditional 3 times per week hemodialysis. But for more, for functional patients, patients who have a home, who have good support, we're always talking, transplant first, get on the transplant list, even though you're not on dialysis. We'll call that preemptive transplant listing. And then, the focus, I try to really emphasize home therapy. If at all possible, I like patients to dialyze at home, either with peritoneal or with home hemodialysis. So, yeah, so I and some of it is me. I'll try to explain to them as much as possible, but then I also refer them quite often to, you mentioned Ramona Wong's Aloha Kidney education class, but also the dialysis companies offer their own education class about choices, and they actually get to see the machines and just get a flavor of what each of the different home therapies are like. And, based on that, we kind of pick our path as far as which way we're going with regards to renal replacement therapy.
You mentioned getting on the transplant list. I've heard that UCSF has a transplant program that people in Hawaii can use. I'm not sure exactly what that is. Can you tell me about
I mean, well, your insurance will have to authorize it. I know, well, Kaiser, for example, Kaiser has an exclusive contract with UCSF. So if you're a Kaiser patient, you actually cannot be transplanted at Queens or be listed, which is quite inconvenient because, there's quite a bit of follow-up involved with that and whatnot. So I personally, if I were a Kaiser patient, I personally probably wouldn't like that. But I mean, no knock against UCSF. I mean, they're a premier institution. They're probably one of the great medical centers in the United States. So, I mean, it's the quality is definitely high. But just the flight to California, and especially in this day and age of COVID, I think it even more so kind of magnifies some of the inconvenience and maybe even the danger of having to travel. Especially with COVID going on. So UCSF is one of many transplant centers on the West Coast. Hawaii does have Queens Medical Center. It's a fairly small program. But, I send a majority of my patients to Queens. I would say 99% of my patients. And, occasionally I'll have patients who request to be dual listed. So they may request to be listed at Queens and then listed at another center in a different region of the country, just to kind of expand their exposure to the donor pool. It might increase the odds that they get a transplant sooner. or there might be reasons, they have family in California or Oregon or something. They want to be listed there too. So, but majority of the patients I actually refer to Queens for their transplant listing.
Do any patients choose mainland hospitals due to the racial makeup around the hospital in the hope that they may have more compatible donors there?
I've personally never had a patient that had that reason for choosing to go to a mainland hospital. If anything, kind of the racial profile in Hawaii. I mean, if you're from here, and maybe you're racially actually maybe more likely to find a better match being in Hawaii. But obviously it's a case by case basis. But I've personally not had a patient who's made that choice. Majority of the time, it's because they want to just kind of have an expanded donor pool, from which potential kidneys could be given to them. So it may increase the odds, especially if you're going to a region, say like Florida, where the average wait time is a lot lower than say Hawaii might be.
Mm. Do you get involved at all with family members who are considering being donors for?
To some extent, yeah. To some extent, I mean, that evaluation. So the living donor evaluation is done at the transplant center. So they're the potential donor is put through the ringer because they have to be medically. I mean, you definitely want to make sure the person can handle losing a kidney.
Right.
You want to really make sure that the risk of them developing end-stage renal failure later is as low as possible. It's never zero. Mm-hmm. I mean, donating a kidney does come with risks, but you want to try to really do a thorough evaluation to make sure those risks are as minimal as possible to the donor.
So after the transplant, you again become involved in the routine care of the patient?
Yeah, so immediately post-transplant, Queens holds on to them for roughly about a year. And that's usually when a lot of the post-transplant complications will arise. Early on, it's going to be surgical complications. And then later, it's going to be more medical, immune suppression related complications, a lot of opportunistic infections, viral infections. Those tend to happen, and rejection too, because rejection is most vigorous the first year after transplant. After the first year, things really tend to stabilize. And that's usually when Queens, kind of lets go of them and then sends them back to their referring nephrologists. And so that's usually when I inherit the patients back again.
What are the biggest challenges you see, I guess, just in general medical care for a transplant recipient?
I mean, there are numerous challenges. They're chronically immunosuppressed, and really, one of the big challenges is trying to strike the balance between preventing the kidney from rejecting versus over immunosuppressing the patient and having them susceptible to a whole host of opportunistic infections and malignancies that can occur with prolonged immunosuppression. That's a real difficult balance because, I think sometimes as nephrologists, our focus is really the kidney and we forget about the patient, right? And so we're so focused on keeping the kidney alive, the transplanted kidney alive, that we forget that these medications are very, very powerful. And, the patient's getting recurrent skin cancers or getting lymphoma or, immune suppression related infections and malignancies. And so I think the number one priority is always, save the patient first, before above all else. It's really the patient. The patient is not a kidney. I mean, what good is a live kidney with a dead patient, right? So
right.
I think that as long as you kind of follow that mantra, and you allow that principle to guide you, you'll be okay. So it's really striking that balance, because we can really suppress someone's immune system so they never reject the kidney, but we'll lose the patient, they'll die of a, lymphoma or something from immunosuppression. So yeah, just trying to achieve that balance is difficult sometimes.
What's the general advice given to transplant patients about trying to avoid infection?
I think a lot of it is really avoiding unnecessary over immunosuppression and really just paying attention to what the patient is showing you. I mean, this is not so much on the patient side, really it's on the clinician side. but really noticing, like, are there hints that the patient may be over immunosuppressed? So we for example, we use a medication called tacrolimus. It's one of 3 immunosuppressants we use, and we target a level. So we want the level to be about, after about a year, we want the level to be anywhere from 4 to 7. But I think if you focus so much on the level and not so much on what's going on with the patient, I mean, you can miss things, right? You miss that the patient has had 6 skin cancer resections in the past 3 months. But their level is fine. Their level is 5.
Right.
They're fine. But it's not just the level. I mean, you really have to look and see what's going on with the patient. Their CMV is reactivating, or the BK virus is reactivating. So we can sometimes miss these subtle hints that they're being over immunosuppressed because we focus so much on the level. So I think a lot of it is on the clinician to really watch for, actively do surveillance for signs of infection and over-immunosuppression. On the patient side, general recommendations: no live virus vaccines. So you can get. So there are different types of vaccines. So the COVID vaccine, for example, is an mRNA vaccine. But there are certain vaccines, for example, like the shingles vaccine, which uses a live but weakened form of the virus. Those are contraindicated in patients who have solid organ transplant because of the risk for activation. The other thing is no raw foods. So, definitely no sashimi, no poke. And that's actually a hard one for our local population.
What's the risk associated with raw food for them?
Well, because their immune system is suppressed, so they're immunocompromised. Any bacteria or parasites that are living on those uncooked foods could potentially turn into an opportunistic infection. So our immune system, our host immune system, protects us from these bacteria that live on the raw foods. Cooking kills all of that, right? But if you're eating it raw, your whatever's on there is going to get absorbed. And normally our immune system's pretty good, but even patients who have a competent immune system will sometimes get, quite sick from eating sushi, or, I think, eating, scallops that are contaminated with hepatitis A. But if your immune system is compromised, that risk of illness is magnified. So because of that, we recommend avoiding raw foods in patients who are on chronic immunosuppression. The other thing I always counsel on is just routine primary care. Get your pap smears, get your mammograms, like, for example, cervical cancer is an infection-associated malignancy that can be, made more aggressive because of immunosuppression. So you have to get routine, and then routine skin care. So at the very least, annual dermatology examinations. I tell all my patients, you got to do at least monthly self-skin examinations, and then avoid direct sunlight, sun avoidance, because
that's easy.
Because of the, yeah, I know, living in Hawaii, but because of the immunosuppression, skin cancers are a big risk factor.
Right.
And these types of cancers are actually infection driven. So, well, some of them are, not all of them. Some of the cancers arise because the immune system commonly surveys for cancers and actually what keeps cancers in check. But a lot of the malignancies, like the lymphomas, for example, that we see with immunosuppression and kidney transplant, those are related to viral infections. The Epstein-Barr virus causes post-transplant lymphoma. It's the same thing that causes mononucleosis, but it can cause lymphoma in transplant recipients. So the malignancies that we often see are related to immunosuppression, and they are sometimes related to infections, chronic infections.
Has COVID changed the advice you give to patients or how you treat them?
I tell my transplant patients, you have to be extra vigilant, because a transplant patient, because of immunosuppression, they're at significantly higher risk. I was reading one site, like 30% higher risk for, mortality and complications from COVID versus, the general population. So that's definitely an issue. So if they were to acquire COVID, it's going to be it could be potentially more devastating. The second issue is just, with the vaccine, right? So there's still no documented safety of the COVID vaccine in patients who have received a solid organ transplant on immunosuppression. The theoretical risk is, will the vaccine induce rejection in the transplanted organ? Because it does stimulate the immune system. I personally doubt it. I think it's not going to have any problem. I mean, we give the flu shot, the influenza vaccine to transplant recipients. There's no problem. So I don't think it will, but I know that medical centers, like for example, Johns Hopkins is currently enrolling, transplant recipients and actually looking at this specific issue with regards to the safety of the COVID vaccination in solid organ transplant recipients. So that's another issue. And a lot of our transplant patients are asking, is it safe for them to get the COVID vaccine? And I don't have a standard answer. I really think it's a case-by-case basis. I mean, for example, I have a transplant patient who is a dental hygienist who is up, like literally, in inches from someone's mouth, right? And so they're going to be at very high risk for, catching COVID. So given the profession, we had a discussion and I actually recommended that the patient get the COVID vaccine, even though, there isn't documented safety because it would, her risk of acquiring COVID is really high, even with proper PPE, just given her profession. Whereas my other patient who, he's a transplant recipient, works at home, never goes out, doesn't even go grocery shopping, has everything delivered. I mean, pretty low risk. So somebody with him, like, his situation, I said, maybe let's wait till the Johns Hopkins data comes out and we can see if it's safe or not. So I would say it's a case-by-case basis.
I've read that chronic kidney disease is more prevalent in Hawaii than on the mainland. Has that been your experience? Native
Hawaiian Pacific Islanders actually have the highest rate of end-stage kidney failure amongst any ethnic group in America. Just to give you reference, so there's about, according to the statistics, there's about 2,500 per million for Native Hawaiian Pacific Islanders, with regards to advanced kidney failure, ESRD, versus 2,500 per million versus 250 per million in Caucasian, in the United States. So yeah, we have, and obviously we're in Hawaii, so we have the largest concentration of Native Hawaiian Pacific Islanders. So yeah, just that ethnic population alone just has a disproportionate burden of kidney failure, chronic kidney disease.
And are there theories as to why that is?
It's probably multifactorial. I mean, some of it could be genetic. A lot of it has to do with rates of diabetes. So you do see quite a high percentage of diabetes in Native Hawaiian and Pacific Island populations. And but even with the diabetes, just from my personal observation, it seems like maybe in other ethnic groups who may have a similar degree of diabetes, Pacific Islanders just seem to get the kidney disease much earlier and much more severe, even at comparable levels of diabetic control. So there may be some other components. I know, like for example, in African American populations, they too have disproportionately high rates of kidney disease and stage kidney failure. Not quite as high as Native Hawaiians and Pacific Islanders, but very, very high. I know in some situations with that, there are some genetic predispositions. So there's actually a recently identified gene called the APOL1 gene mutation that is fairly commonly seen in African Americans, and that gene mutation is associated with kidney disease. So there might be some genetic risk. There are a whole host of other risks. So, for example, your birth weight is also a risk for having chronic kidney disease later in life. So if you had a very low birth weight or if you were premature, that would potentially put you at risk for kidney failure later in life. So, and there may be some socioeconomic contribution, access to healthcare, access to, high quality, healthy foods. So I think there are a lot of potential reasons that probably interplay and leads to higher rates of kidney disease in certain ethnic populations.
When a person is judged to be in stage 1 or 2 of kidney disease, is there treatment available to them? Can they prevent their kidney function declining even more?
Well, I think to answer that question, we really need to take a step back and actually find out why are they in stage 1 or 2 chronic kidney disease. So, chronic kidney disease is really just the endpoint of a variety of literally hundreds of potential diseases that can cause chronic kidney disease. So, for example, if I had a young woman in her 20s with a history of lupus who has a normal GFR, let's say the GFR is 90, so, but she has some protein and blood. So technically she's stage 1 kidney disease, but she's got protein in the urine and blood and a history of lupus. Even though the GFR is normal, depending on how much the lupus is affecting the kidney, she could be at very, very high risk for, kidney progression and kidney failure, and sometimes quite quickly also. So, obviously in somebody like that, no matter what you do dietary wise, you're not going to slow down kidney disease. So, I think in order to answer that question, you really have to determine, why does the patient have chronic kidney disease? Why am I seeing protein in the urine? Why am I seeing blood in the urine? What's the reason? And you need to treat those reasons. So, for example, the most common cause for kidney disease is diabetes, diabetic nephropathy, diabetic kidney disease. So, if you catch somebody early with diabetes, they've got a little bit of albumin and protein in the urine, they have essentially a normal GFR or stage 1 or stage 2 kidney disease. Dietary lifestyle changes to help control the diabetes will slow progression. But if they have another reason for their kidney disease, let's say they have lupus, or they have another autoimmune disease, or some sort of, I don't want to use, these confusing medical terms, but, for example, multiple myeloma, or, any one of hundreds of conditions, it doesn't really matter what you eat. I mean, you got to treat the underlying disease. So I think in order to answer that question, every time I see a patient, every time a patient's referred to me, one of the first things I do is I ask why. Why do you have chronic kidney disease? Chronic kidney disease doesn't just happen. There's a reason. And so we do a pretty exhaustive medical evaluation, sending blood tests, even a kidney biopsy, to try to figure out why. Because unless you actually figure out why, you're not going to slow progression.
Right. That makes sense. Is there anything else you would like people to understand about chronic kidney disease?
Well, I guess maybe the most important thing is a lot of times chronic kidney disease is silent until it's very, very advanced. And so, unless you're getting routine medical care, you may not know whether you have chronic kidney disease or not. So it's actually really important to, at the very least, get your blood pressure checked, get some basic kidney labs, a urine test done, and especially if you have a risk factor for chronic kidney disease, like hypertension or diabetes, so just pay attention to your health, get your regular, primary care, not necessarily just screening for chronic kidney disease, but make sure that's something that's looked at, because otherwise you may not know. And I can't tell you how many patients I've had who have just neglected their health, not seen, a physician for many, many years, who come into the hospital essentially with stage 5 kidney disease, and I need to start them on dialysis like that day, but this has been brewing for months. They knew something was wrong. Their legs were getting swollen. They were getting headaches, blurry vision, and just finally it got to a point where they just couldn't take it anymore, decided to go to the ER, and their GFR is 2. In fact, I just had a patient who I'm discharging from the hospital today. That's the exact story. He hadn't seen a doctor in over probably 20 years. Young guy too, only in his 40s. But
that is scary.
Had to start him on dialysis the day I met him in the emergency room. Yeah. Thanks
so much for taking the time to talk with us today, Dr. Hayashi. I really appreciate your perspective and the knowledge you've provided. Thank you.
I enjoyed it. Thank you so much, and take care.
You too.